Zoom recording. So we have two presentations today. Apologies for the change. There was a family emergency for our third speaker, so she will be rescheduled to the fall. So we have Kristin Rosinski from the PBCO here in British Columbia, and she's a medical lab technologist working with PBCO. And she's going to be talking to us about centralized screening of IVIG for central nervous system conditions and doing a 1-year post-implementation. The second speakers will be Liana, Perruzza, and Winckler, and they are both transfusion medicine nurse clinicians. Liana's at Providence Health and Tara is at Vancouver Coastal, and they are going to be talking about how to succeed as a transfusion practitioner developing the handbook. So I will stop sharing my screen and I'll hand it over to Kristin to start.
Great, thank you, Dr. Marcon. And do you see my screen? Yep.
Yes, I see. Yeah, thank you.
Perfect, thank you. Okay, so as Dr. Marcon mentioned, my name is Kristin Rosinski, and I work at the BC Provincial Blood Coordinating Office. So this presentation is in relation to the neurology program we've developed at the BC PBCO, and doing a little bit of a 1-year post-implementation review on the program and what we were able to accomplish with it. Recognizing that my slides are, the poster that was developed is essentially just 1 or 2 slides. I've actually gone a little bit into the history of the program to give you a little bit more of an overview on why it was developed, what it does, and how we made the decisions we did. So thank you, Dr. Marcon. You've already done a land acknowledgement. I appreciate that. So I will skip over this. I have no disclosures except to state that I started working at the BC PBCO in early 2021. So many of the references that I am talking about are not decisions that I was involved in. When I say we, I mean the royal we. So delving into a little bit of the BC PBCO history. So the Blood Coordinating Office was established back in 1997 as an advisory body to the BC Ministry of Health following the tainted blood scandal. PBCO was essentially created to address the recommendations that came out of the Krieger Commission. There were 50 recommendations that came out, and so a wide variety of what we do is in relation to these recommendations. The Central Transfusion Registry was created in 1999 to house records of recipients who've received blood components and blood products in British Columbia and Yukon. It was designed essentially to store all transfusion reaction data and used to support the Public Health Agency of Canada for reporting purposes. But we've used it to expand our program and allow us to review conditions related to IVIG and SCIG use. So that's why I reference that. Some of the major initiatives at PBCO, these are 5 of our major initiatives. With contingency plans, using resources from the National Blood Shortage Plan and guidance and input from the Transfusion Medicine Advisory Group, we develop and maintain a provincial blood shortage plan. Similarly, with the expectation of a national IG shortage plan to be in the currently in final review phases, we plan to work to create a national IG program. So that's just one of the major initiatives of PBCO. We also support redistribution programs to reduce wastage with relation to red cells and factor products. We partner with stakeholders across all of the health authorities, Ministry of Health, and a variety of other institutions, and have a bunch of different working groups that we work with. We maintain provincial responsibilities and resources related to the Krieger Commission. And of course, IG utilization management is a huge one because it is such a scarce resource. So just a little bit about the history of the BC IG program. So going all the way back to 2002, a provincial IVIG guideline handbook was created. In 2004, the PBCO started centralized screening for all IG requests. That was discontinued very short after because it was not something that was manageable. In 2008, the rheumatology panel was developed, where all adult rheumatology conditions were screened by a panel of experts. And then in 2013, directives were issued from the Ministry of Health with relation to IG use. So I'm just going to go ahead to the next slide to show you some of those directives on a broad scale, and then I'll come back to this. So the directives were related to minimizing wastage with a goal of zero outdated product, dosing using adjusted body weight calculation as much as possible, regular evaluation of clinical effectiveness. And then with relation to screening, it was expected that any of the approved conditions would be screened at the hospital setting to ensure that the dose and the conditions and the dose and the schedule are in line with the approved conditions. To implement specialist screening. So this at the time was directly related to the rheumatology program, and now would it be in relation to the neurology program? And then site hematopathologist screening of additional requests. So anything that wasn't on the approved list or specialist list would essentially be screened by site transfusion medicine physicians or hematopathologists. And then that the reporting, and that the reporting or all usage was tracked and retained. I'm just going to go back to the last slide. So then in 2014, the PNS, or at the time was referred to as the neuromuscular centralized screening program, was implemented. In 2015, they identified that primary focus for further utilization review would be immunology. And then in 2020, we launched the blood product request portal, which allowed us to get better data with relation to the conditions that IG was being used for, as well as ordering physicians, contact information, that sort of thing. And this is kind of our conduit to the health authorities, where all of our data is housed and feeds directly into the CTR application. And then, of course, in 2023, we launched the harmonized neurology program, which is what I'm going to continue talking about. So going all the way back to 2012, 2013, when we looked at the utilization and the trends, it seemed that immunology was on the rise, neurology was on the rise, and then other conditions weren't nearly as broad. We knew that neurology was another area where there'd been significant use beyond the Health Canada recommendations. So then when we extrapolated that data a little bit further, to look at the top conditions, the top 5 conditions were already the Health Canada approved conditions. So this is primary immune deficiency, chronic CIDP, SID, secondary immune deficiency, ITP, myasthenia gravis. And then this is a rheumatology condition, polymyositis. So then the next 5 biggest utilization were all neurology. So this is vasculitis, stiff person syndrome, non-specific neuropathy, and encephalitis. So then we introduced the neurology screening program in the 2012-2013 year, specifically again for peripheral nervous system conditions. And so this was the kind of the guidance back in the day, back in 2013 for the program. So on the left, we have the Health Canada approved conditions like Guillain-Barré, CIDP, MMN, and myasthenia gravis. And then we had what were called possibly indicated conditions. And these were the ones that would be screened at a panel level, where the panel of 3 experts would review them and make an informed decision based on a combination of patient outcome as well as literature on the conditions. And then there's a handful of conditions that were considered not indicated, and these would be denied at the health authority. Skipping ahead to 2021, 2022, when we continued to develop the neurology program, we moved into the central nervous system conditions. So in each annual review, it was noted that while patients with central nervous system conditions have a small overall use of IVIG, it was growing quite rapidly. And so back in 2021, when we looked at the historical data, the blue section, bluey green section here is neurology, and you can see this 37% of all IG use was neurology. So we looked a little deeper And at first glance, almost all use for neurology is PNS conditions. So all these blue bars were peripheral nervous system conditions, which we already had a program for. And the central nervous was just these little orange ones. And then other didn't really fall into a category at the time. And then multiple means there were multiple conditions. But when we removed the conditions that were already approved by Health Canada, then you could actually see what was going on with the data. So the PNS conditions that were coming to the panel for review were in 2016, 2017, were about half of all neurology conditions, or actually not even when you consider the others. And so the light green is the central nervous system conditions, and the dark green is the peripheral nervous system. And so when we removed all those Health Canada reviews, Health Canada approved conditions, you could see how fast the central nervous system conditions were growing. And so an assessment was performed on the current IG use for neurology cases. So when we reviewed the data, we discovered that the term other was used a lot. And so we didn't really know what that was. Miscategorization was common, so things were being entered as the wrong condition. Some terminology was outdated, and new research and data had become available since the program had launched in 2013. And so this is just a broad timeline of the CNS program development from concept to implementation, and of course, evaluation following the program implementation. So it took a long period of time because we needed to develop the diagnostic criteria and prerequisites to figure out those recommendations and what outcome measures we wanted to see, to review the data with all of the experts. Our current panel of neurologists are PNS experts, not CNS experts, so we needed to engage in further working group members to ensure that our task force was essentially appropriate for these conditions. And of course, we had to engage with stakeholders to ensure that the tools and resources we were developing for them were kind of in line with what they needed to ensure a smooth and successful transition. So resource development. So our PLMS, our Provincial Lab Medicine Services Analytics team, pulled historical conditions for us to review. We had a group of CNS experts who reviewed the CNS conditions where IG is known to be effective, and the historical conditions reported by BC sites. And then our current PNS panel, they reviewed the current list of conditions that we already had and the historical conditions reported by hospital sites. From there, we were able to split up that old, I guess you refer to them as categories, where the Health Canada approved conditions, and then we had what was called possibly indicated, and we split that possibly indicated down further into conditionally approved and approved only in exceptional circumstances based on the literature around them. And so we developed these 4 classifications for peripheral nervous systems. And then because there's no Health Canada approved conditions or no conditions approved in BC specifically for central nervous system, we had no approved category for central nervous system. And so we broke it down and essentially we're able to make these resources. So this is just essentially lists of conditions. So we have our conditionally approved on the far side, only in exceptional circumstances, and then not indicated. And then for peripheral nervous system, we're able to break it down with approved, conditionally approved, only in exceptional circumstances, and not indicated. And at the very bottom, it explains how these are handled. So approved conditions continue to be screened at the health authority, while conditionally approved would be screened at the health authority for 3 months so that we could have some data on the patient's outcomes. And then it would come to the panel after that. Only in exceptional circumstances come to the panel, and it was expected that anything not indicated would be denied at the health authority. And then we developed these complicated, which aren't really all that complicated, lists of what a new request would look like and what a renewal request would look like. But essentially, review the conditions, send it to transfusion medicine, and then for any renewals, the PBCO will follow up directly with the ordering physician to get any information we need. And then we further developed a guide for screening physicians and technologists, specifically our utilization management coordinators at the bench level. And And so we developed these documents. So this one specifically is the treatment of neurology conditions, which breaks down what approval category does it fall into, what's the mnemonic in our application, what's a standard initial treatment and a standard maintenance treatment. And then this is just sort of from what our website looks like. On the central nervous system section of IVIG neurology, there's lists of individual conditions that you can click on. And within each of these are more detailed specific clinical prerequisites, treatment recommendations, and outcome questionnaires, or outcome measures, sorry. And it also references site literature for you for further review. We made template order forms, outcome questionnaires, and internal screening processes and updates to the application to allow for screening practice. And then what this presentation was supposed to be about was just what did the first year of this screening program look like? So specifically to the central nervous system side, only patients aged 18 or over were reviewed. Only IVIG patients were assessed, as the program doesn't currently handle SCIG. And using the criteria previously presented, they were screened based on the 3 categories I just reviewed. And so essentially the panel would review individual cases, they would compare them against the recommendations, they'd send a letter to the ordering physician, and then the CNS expert panel review would review every case on a 6-month basis. So they would be approved by our peripheral nervous system experts by reviewing the literature, and then brought to the panel of CNS experts to ensure utilization is appropriate. And so just looking at what kind of cases we were looking at. So the total on the left, you can see the total central nervous system cases. So 27% were antibody-mediated autoimmune encephalitis. And so this is essentially, it encompasses both first-time requests and renewal requests. And then the CNS cases that were screened by the panel. So once you remove those first-time requests, it kind of leaned out the data a little bit. And so you can see several of these conditions didn't actually come to the panel for review. So it's as if that first dose wasn't necessary, or the first 3 trial doses wasn't necessarily improving outcome measures. Whereas conditions like AMAE and severe disabling drug-resistant non-surgical epilepsy were more commonly coming to the panel for renewals. And this is what's really interesting about the data, is that the panel reviewed 85 renewal cases in total and provided recommendations, and only 1/3 of the recommendations were to continue therapy as the ordering physician was ordering. Essentially, there was a lot of recommendations to trial a reduced dose or to trial a reduced dose and alternate immunotherapy. So really, in summary, IVIG has been shown to be effective in the management of some CNS inflammatory conditions, and using this physician-led utilization program in BC in conjunction with targeted education to the ordering physicians, the program promotes best practice and assists in the overall utilization management of IVIG. And so lessons we've learned from this first year of screening will inform our future versions of these recommendations. And then on this slide, I just have some QR codes for reference in case you wanted quick snapshot of any of these resources. They're all at pbco.ca under IVIG section. And I just want to wrap it up by gratefully acknowledging our provincial neurology panel members, Dr. Beaton, Dr. Gio, and Dr. Chapman, the provincial CNS experts, which is a whole variety of central nervous system experts, program oversight by our medical directors during that time, as well as our PBCO business operations team. That's all. Thank you.
Thank you so much, Kristin. That was great. And thank you for the overview, and definitely taking up a lot more time. Thank you, because otherwise we only have the 2 speakers today. I do have some questions, and I think we'll have time. So
Absolutely.
I'm wondering, because you're showing that last pie chart showing that the majority of these cases were the panel decided that they shouldn't continue either at the same dose or at all. Do you have any thoughts, or maybe other people on the line have thoughts about whether or not there was discussion if the first doses were appropriate at all. Like, was this an appropriate trial of IVIG for these indications, or should these conditions just be like, no IVIG at all because it's not going to work?
Yeah, so if you look at our program resources, the neurologists did a really deep dive on whether or not specific conditions were truly appropriate for IVIG at all. And so there's some cases like multiple sclerosis where they flip-flopped and nope, shouldn't be allowed at all. Well, maybe really rarely it should. And then, that sort of thing. And so when they continued to deep dive and get panel recommendations, that's where they decided how to categorize them. So there's only a couple of conditions that are considered only in exceptional circumstances, which they figured aren't necessarily appropriate for IVIG, but in certain circumstances they may be. And the reason that we do it this way to trial that first dose is because we don't know how the patients are going to respond. And so the expectation is to trial 3 doses and see what that clinical review looks like. And if the outcome measures show improvement, that's how the panel decides the appropriateness going forward.
Awesome, thank you. Does anybody have any other questions from the crowd? I have something else, but if no one else has any questions, I can ask it. Oh, Doug has something.
Thanks, Krista. And thanks, Kristin. That was a great summary. I guess I had a similar question to Krista around, those 2/3 of the cases where there was either a recommendation to discontinue or reduce the dose, trial a lower dose. Do we have any follow-up data on whether the attending physicians responded to those recommendations?
So essentially the way that it works in a lot of cases is there's a communication directly with the screening physician and the ordering physician to have a conversation. And so these aren't necessarily just recommendations letters that are sent out suggesting alternate therapies or whatever it is. It's typically a conversation between them to discuss why they want to continue to trial and that kind of thing. I can say that there are some physicians who are apprehensive to trial anything other than what their initial thoughts were. And that's definitely a theme that we see, or there's a few physicians who aren't super concerned with the recommendations of the panel and want to stick to their processes. But we do plan to continue to track these patients, and we are tracking them kind of long-term to see what changes occur.
My next question is about others, obviously outside of CNS and what you've talked about. So this is obviously amazing for us from the health authority level, that things that I think in transfusion medicine and hematopathology, we don't have any expertise about, that having these panels are awesome. Is there any thought to add further panels for things that aren't hematological related as well, that are also potentially out of our wheelhouse, like immunodeficiencies, rather than having that being screened at the transfusion medicine health authority level?
Dr. Morrison's nodding his head, so I don't know if he wants to answer, but we have started engaging with respirologists specific to secondary immune deficiencies, which kind of leads into requirements to change our recommendations around primary and secondary immune deficiencies. But whether or not there's a panel in the future, I don't know. Dr. Morrison, did you want to say something?
Well, I think Krista, that's a particular area, immunology, primary immune deficiency, secondary immune deficiency, where I think we could benefit from a provincial panel, those are the big areas of use in the province. So definitely something I would like to pursue at some point. I did want to mention that the QR codes that Kristin shared for those 3 resources on the PBCO website. Those are resources that I think are really excellent for when you're screening requests for CNS neurology conditions, because, you know, even just understanding the condition, there are one of those resources that Kristin highlighted, you know, very nicely describes the sort of diagnostic criteria for those conditions, the recommended, you know, approach to therapy. And then there's another resource that's sort of a crosswalk that allows you to, you know, when you have a diagnosis that, you know, you're not sure where it belongs, what category it belongs in, it's useful in that regard. So I'd really encourage people to have a look at that. And Krista, your other question about, you know, the conditionally approved conditions, the ones that have rather short-term courses of therapy, those are the ones that I guess as a TM physician you're most commonly faced with and the decision to make. So I think, you know, those resources are helpful in that context, but in terms of impact on the global use of IVIG and sub-Q immune globulin, the things that really drive the use are long-term use, and that's where I think the focus is. I think that part of that approach was motivated by the neurologists, the clinical panel, recognizing that they often face conditions where they may have little to offer clinically, or they believe a trial of IVIG is appropriate. And I know that's you know, they're sympathetic to that, to be quite honest. And I think that it's, you know, to reassure you, it's probably not a major factor driving the use of IG globally. It's probably that chronic, long-term, lifelong use of IG that really drives utilization and the number of patients. So anyhow, thanks very much, Kristin.
Yes, thank you so much. Unfortunately, some of these, though, like with slightly different processes for all the conditions, does add extra challenges for our health authority, particularly in the era of Cerner, and making sure that these patients have their approvals before they're scheduled for their follow-up doses in MIC, because that's where our, you know, the current processes for rheumatology are a bit more slick, I think, than the neurology. So that's just extra challenges that we deal with on the health authority side. If there's no further questions, though, we will proceed to our next speakers. So I will invite Tara Winckler and Liana Perruzza to share their screens and start their discussion. Thank you so much. And you're muted, Tara.
So, yeah, no, sorry, I just realized that. I'm just trying to figure out which screen I need to share. Sorry, guys. Can you all see like my presentation slide, or do you see my notes?
That looks perfect. We see the presentation.
Okay, awesome. So thank you very much, Krista, for inviting us, Liana and myself, to speak this morning about our transfusion practitioner handbook. As you mentioned, I'm the nurse clinician for transfusion medicine for Vancouver Coastal. I'm one of two. And then Liana is the nurse clinician for Providence Health. We have both been in our roles now for a few years, but we had very different starts to our roles, i.e., when I started in my role, I had my predecessor, Shelley Feenstra, with me to provide guidance and mentorship support as I started. And unfortunately for Liana, her predecessor wasn't able to be there for her when she started. So one of the things that was created for Liana was an orientation book, which I then stole when I was orientating my first partner clinician, and then also used to support Caroline when she started as my partner clinician last year. But out of that came this idea that maybe we should have a guide for anybody who's starting in this role. And that's where that was the genesis for our Transfusion Practitioner Handbook. So I'm going to go through kind of the introduction, the design and methods, the results and conclusions. So we sort of decided that transfusion practitioners, what we do is we support the development and implementation of transfusion medicine best practices, primarily for nursing or other clinical staff, but also with the sort of overflow into technical and medical as well in some situations. We all have a pretty diverse professional background and pretty extensive knowledge beyond transfusion medicine. For example, Liana comes from an ICU background, and I'm actually from leukemia bone marrow transplant. We have an assortment of specialized skills to succeed in the role. It's sort of, you kind of need to have it, but we also come into the role with that. So they sort of, we get a little feedback loop going on as far as that's concerned. It's an emerging role, so at least in BC, it's pretty new. And it's continuously changing to address the changes that are happening in transfusion medicine and the changes that are coming out and impacting on the clinical side of things. Historically, there have been a few tools created, but not many, specifically for education and training of the individuals holding this unique role. So what we did was, for our design and methods, we got started by creating a working group with 3 transfusion practitioners. So myself and Liana, and our main support was Crystal Brunk, who was sort of led us in our work and was instrumental in the creation of this document. We defined our project objectives and scope. So we determined that this wasn't something that was going to provide all of the information that transfusion practitioners needed, but rather be more focused on where they could go for their resources. We did a literature review, so we looked around to see what else there was out there. We did our development of our draft, so we created our initial version of the guidebook, generated a content list, and then sent it out for review by the nursing resource group, the technical resource group, and TNAG, just to make sure that we were covering everything and that people were happy with it. What we came up with was our Transfusion Practitioner Handbook, and it was published and posted on the PBCO website on the 1st of August, 2023. It covers the roles and responsibilities of the transfusion practitioner, the foundational knowledge, sort of courses and training that would be beneficial, local committees and professional organizations that might be helpful to be a part of, how the Canadian blood system works, the provincial blood coordinating office and kind of how that works and how we can lean on it for support and resources. What are the transfusion medicine standards and regulations? Where do we find them? And how many are there? Quite a few. Guidance on navigating accreditation and inspections from the clinical side, which is a pretty big part of our job as well, and making sure that from a clinical perspective, we're all ready to go. And then also looking at blood utilization and patient blood management, hemovigilance, so monitoring of transfusion reactions, and other specialized skills that would be useful to either hone or develop in this role. And then we call it a transfusion practitioner because our title varies throughout the province and even throughout Canada, like what we're actually called. So we wanted to try to cover both, we wanted to try to cover the backgrounds of anybody who might hold this position. So currently we're all nurses. There are 6 of us in BC. But potentially this is a role that could be held by a lab technologist as well. So we wanted to make it as general as possible. So we weren't using language that was specific to nursing, for example. This is what's happened since we posted it in August. So apologies, there's a little discrepancy on this slide. British Columbia and the legend is a dark gray black color, but we're actually the blue in the bar graph. Since we posted the handbook between August and April, we had 122 views in BC, 21 in Ontario, 10 in Nova Scotia, and then sort of about 11 from other provinces across the country, which has been amazing and awesome and wonderful. But what's also been really great is we've had 12 views from Saudi Arabia, 11 from the United States. People are looking at us in South Korea, which is pretty incredible. And then we've had views from 16 other countries as well. So this is that we're actually really astonished that we've had such a wide spread with this. But it's also really amazing. And we're really happy. And then since the STM at the end of May, we have had an additional, so we went from 122 to 137 views in BC, and then a sort of slight increase in Ontario and a slight increase in Nova Scotia. But again, sort of really quite amazing that people are so interested in what we've created, which we're really happy with. So in conclusion, the Transfusion Practitioner Handbook is now available as a resource for current and future transfusion practitioners. We're very happy to share it across the country if anybody is interested in developing something similar. We are using it provincially as the tool for new transfusion practitioners, but it's also being used by others in the TM field to support ongoing education and training. And this is our QR link to the handbook. So please feel free to scan it and check it out. In conclusion, I'd like to acknowledge the support of the BC Provincial Blood Coordinating Office, particularly the PMAG, the NRG, and the TRG for reviewing and endorsing the handbook, and also to my personal thanks and really a lot of thanks to Crystal Brunk, who, like I said, has been pretty instrumental in helping Liana and I make this happen, and also helping with our poster presentation at the STM. So with that, I'll stop sharing and happy to take questions.
Thank you so much, Tara. I'll ask the first question, but if anybody has questions, please put up your hand. So you alluded to this, and I told you I'd probably ask you something like this. So I'm just wondering, I know across Canada, and I think we have people from across Canada here, that the roles are called something different. You know, transfusion safety officers, what I've heard. We have nurse clinicians or clinical nurse specialists. Is there truly a difference to this role, or do you think that, like, is there something they're doing that we're not, or vice versa, or that fits into different people's roles throughout the country?
I think that the terminology is pretty much interchangeable across the country. I don't think the role itself is real. There's a lot of significant differences. Certain people in the role, or the role, may focus on different aspects of what I talked about. For example, Claire from CW and Liana are very involved in monitoring and investigating transfusion reactions at their sites, whereas Caroline and I for Coastal are a little bit less involved with that. But I think the title of the role is just words, right? Like it's the role itself that's important, and I think the role itself is not that different, regardless of what it's called and where you are. I think you just take it and maybe you focus on slightly different things. There might be aspects of it that, like, for example, nurses, we might focus more on education and policy development. Lab techs may focus more on product safety and utilization management. Like, so just to throw that out there. Not to say that nurses don't also look at the quality utilization and inventory management and those things, but it's just maybe your focus is slightly different. And I'll say for myself, one of my most interesting challenges and learning experiences and opportunities has been the difference between the language used in the lab and the language used by nurses, and trying to figure out, first of all, what my lab colleagues are trying to tell me, but then also how do I translate that and relay that information to the nurses on the ward, and I sometimes I feel like I'm doing really well with that, and then sometimes I'm feeling like I'm not really doing all that great, depending on what's going on. And then Liana, do you have anything to add?
No, I think you did a great job. I think just with manual that was created, it's just going to be very generic. So other health authorities or other provinces can use it. And I had the opportunity to speak to some TSOs from Ontario. So their roles and responsibilities are similar, but somewhat different than what we do out here in BC. It's great to have a little bit of the lab background and nursing background so we can actually understand the workflows between both areas. And basically our role is actually to bridge the gap between the ward and the lab as well.
Awesome. Thank you so much. Any other questions? Doug, you're on, I can see you, so it means you have a question.
Yeah. Well, I would love for others to, jump in, and I don't mean to dominate any of these discussions, but I thank you, Tara and Liana, for that work. I was kind of curious, and I think, Liana, you touched on that a bit maybe, but I was curious what sort of feedback you got at CSTM from folks that reviewed the poster. What sort of interest did you have, and did they have any questions for you?
A great question. So yes, I had a lot of interest while I was there. I actually had some physicians from, I think one of the hospitals was Grand River in Ontario, who was trying to implement this role or get funding for the role. So I provided him this resource so that he can use it within his facility. Yeah, I think there was just a lot of positive feedback because I feel like this role is still fairly new within Canada and it is evolving over time, just with products that we're getting and just our workflow. So I think it's great to have a variety of people involved in this role just to provide input as well. So yeah, all good comments and feedback when I was at CSTM and a lot of interest as well.
Awesome. Thank you. Okay, I have one more question. I'm hoping it won't be too inflammatory. So obviously everybody has a different size of hospital and health authority, and just generally in BC, do you think that we're understaffed with our nurse clinician transfusion safety officers, or overstaffed, or just right? How do you feel?
I think Tara could probably speak to this.
I personally think we're under-resourced in terms of the transfusion safety officer, transfusion clinician position in general. I'm not saying it has to be nurses, but I feel like there could be more of us, particularly for the larger health authorities. And Northern at the moment doesn't actually have this position funded at all, or they may have the funding, but they haven't found anybody to fill it, which I think, and I think that having us around makes life a little bit easier for the lab, because we pull some of the more clinical stuff away from lab so that they can focus on doing what they're doing, which is so important to patient care. And I think it relieves them of some of the stress and responsibility of having to follow up with, for example, to follow up with SLS situations that happen on the clinical side. Because I feel like there's not a lot of nurses out there who know what happens in the lab, and there's not a lot of lab techs out there who know what who knows what happens on the wards. And so I think our role is really important, as Liana said, to kind of bridge that gap and bring that understanding to the nursing staff of what it's like in the lab, but to the lab staff of what it's like in nursing. And I feel like the more of us who can do that, the better. And I know for myself that I was the only clinician for Coastal for, a chunk of time here and there, but I'm really appreciative of having Caroline working with me, because it's kind of really helped to make sure that we can do the quality in-depth support of the clinical side of things which I think maybe some others struggle with a little bit.
I wonder too if like why there isn't too many like nurse clinicians or TSOs around Canada is that it's not advertised quite often and people are unaware of this role. So I think just educating people that there is this role would probably be beneficial to spark more interest and having more people within the different health authorities or different sites.
Tyler?
Yeah, I mean, I think I'd echo kind of what you guys have said, and I think it's kind of similar to like infection control, where sometimes it's maybe hard to show the value you're providing, but it really doesn't mean that it doesn't provide value, and a lot of times that value is kind of hard to quantify in any kind of metric, and so it almost is kind of like contingent on services or people advocating for the role, for the need for this role. Out of curiosity, have you gotten a sense of like in your interactions with the different nursing groups, is there a sense for they kind of appreciate you being there to kind of explain things from the lab side to them? Like, because you kind of talked about, you know, interacting with the lab side, but what's your interactions with the clinical side been like? And is that something where it could maybe also be something we could leverage to show the value you provide?
People are always really happy to see me. I don't know if Liana has the same experience. I think they really like having somebody that they can contact and ask questions. I mean, we do a lot of work around ensuring that we have robust and user-friendly resources for clinicians and giving transfusions, and I think they really appreciate the work that goes into that. So yeah, I mean, I think from a clinical side, they like having us around too, but I don't know, Liana.
No, I find they do. I find a lot of hands-on learning actually happens when I'm working at the bedside in ICU. So people are like, oh, Liana's here. She can answer this question about transfusion. And I find that's where a lot of my questions come up is actually when I'm working in the units.
Yeah, and I do a lot of walkarounds. I don't work at the bedside anymore, but I do a lot of walkarounds, and inevitably somebody's pulling me aside to say, oh, you're here, good, I have a question. Or I do a lot of also like in-service teaching, which can sort of address knowledge gaps that come up in SLSs, like sort of things like that. And I think that's always generally very well received. And I think it just helps the nurses to know that they have a contact person who's a nurse, who speaks their language and who understands where they're coming from and who knows what it's like to work at the bedside. It just sort of makes it easier and more comfortable for them to reach out so that they know, like they know their point of contact person, I think. And that's also been really helpful.
Yeah, because maybe there's something they have a question about, but if they didn't know who to contact, they would just not do anything with that. But at least by knowing you and having that relationship, they can reach out and have it clarified.
Yeah. And they do. I got a phone call yesterday from a nurse who'd never given prothrombin complex concentrate before. And so she called me to find out how she should do it. And I take a lot of calls like that. And I think it just makes them more comfortable and it makes them more confident in their own practice, which is what we're here for.
Totally. Thanks.
Thank you both. And in case no one has ever said it, we obviously do truly appreciate the role that you guys do for us in the hospital. I don't think we would do as well as a transfusion service without having that that connection with you guys onto the clinical service. So yes, we truly appreciate all the work you do and love the interactions that we have together. So thank you. Doug, do you have one last final saying?
I do.
Go ahead.
I just wanted to kind of reiterate the appreciation that we have as medical directors for our TM practitioner colleagues. And I kind of wanted to also say thanks to, the original folks that were in those positions in the province. It's nice that we now have, positions in each health authority. And that was, I think Liana alluded to that, it's difficult to establish the position in the first place. And, back in the day, I guess, a couple of those positions began as autologous nurse positions, for autologous transfusion, and they evolved into the safety. But I just wanted to thank Shelley Feenstra and Donna Miller and Claire for, for a long time they were the only nurse practitioners or transfusion practitioners. So we're really lucky to have everyone now. So thank you.
Well, thank you very much, everybody, for attending. So our next one will be in the fall in September, and I'm going to ask that you bear with me for the technical challenges. Hopefully, we can just delete all the old invites from your calendars, which you will see probably if you signed up for the whole series, September, October, and November, and December. So I'm hoping that we can maybe just do a one-time registration for every single future rounds. So I'm not sure where those multiple links came from. I've never created a second one, so everything should have linked to the same link. But thank you for being patient with me, and hopefully we can get it sorted by September. See everybody in the fall.